He's a professor and co-lead of the kidney cancer program and chair of academic affairs at City of Hope. He's going to be roaming the group. As we lead, he will be herding questions and intercepting projectiles. We're good?
Right here, yeah.
Okay, wonderful. So, Tom, you're first.
Fabulous. Thank you for inviting me. Each year I come here and moan about being next to the Boston Tea Party and what a mistake it was. I'm not going to do that this year.
Okay.
Although I would say your taxes are still higher now than they were then. If you're going to have a king, why not make it Charles III? There we go, a couple of quick gags. Okay, I'm not talking about that. I'm talking about QTWiST analysis, actually, within the context of the Belzutifan Everolimus study. QTWiST is something, who did the COMPARS trial, pazopanib, sunitinib, back in the day? Tony Chiweri, put your hand up. Laurence, were you involved in that study? Oh, no, it was Bernard Escudier. Where's Bob Motzer? Bob, are you here? Bob,
here.
Fabulous, yeah. So within the context of that trial, that was actually when we go back in time, I've only got 5 minutes, haven't I?
You got 5.
When one goes back in time, the quality of life analysis in that trial and the work that was done was really terrific. And when you go back, we can learn a lot from the past. And they did fabulous work in that, including TWiST and QTWiST analysis. And QTWiST and TWiST analysis is really looking about the quality of life, but also the time of that benefit, not just these black and white time points. And in my opinion, I think it is of value, and we've done that here in the context of LightSpark 005. These are my conflict of interest. So the background, I'm not going to go through the study too much for you. For those of you who've been on the moon for the last couple of years, it's a positive trial for PFS for response. It didn't hit overall survival. It had a distinct toxicity profile. The toxicity profile here, you can see which one's better, impossible to tell from this analysis. This is important, of course, because it tells you in detail for your patients what's going to happen, but it doesn't tell you how well tolerated the drugs are. The quality of life analysis that was presented at ASCO GU a couple of years ago showed benefit in key areas like the EQ5D for Belzutifan versus Everolimus. My experience of the drug is that it is well tolerated. It causes anemia, it causes some hypoxia in some patients, which is reversible. But overall, it doesn't have some of the chronic toxicity you see with VEGF TKI therapy and some of the chronic toxicity certainly associated with Everolimus. So what is TWiST analysis and what is QTWiST analysis? Here, this is actually a simple Kaplan-Meier curve. The top of the blue line is the PFS, and the top of the red line is OS. So the red area is the difference between PFS and OS, and that's called REL. The yellow area, TOX, that is patients who are progression-free, but they have significant toxicity during that period. So the good period, I guess, is the blue area. No toxicity, progression-free. Okay? Now, QTWiST is the quality of that area. So if you go back, as they did at COMPARS, and you look at the quality of life metrics, if you assume 1 is perfect quality of life and 0 is terrible, no quality of life, but the same as being dead, you can... That's true, by the way. That's true. That is a matter of fact. That wasn't a joke. Under those circumstances, you get a score between 0 and 1, and each drug gets a slightly different score. That is QTWiST. Okay. This is the detail of that method, and this is the detail of what we did, which I haven't got time for today, but I'm happy to answer any questions on. So, on the left-hand side, you can see here the Belzutifan curve. On the right-hand side, you can see the Everolimus curve. The top is the overall survival. The jagged is PFS because of the CT scans. The red is the toxicity. You can see the PFS advantage associated with Belzutifan, and you can see the green area, the area without toxicity, is larger for Belzutifan than the area for Everolimus. And then when you do the quantified analysis and you look at that area, and then you do the multiplication by that quality of life metric, you see two things. Firstly, you see that area is larger in terms of time without toxicity and without progression for Belzutifan. And secondly, you can see when you compare that to Everolimus, that reached clinically meaningful levels and not just statistically significant levels. Now the challenge with this is who sets the parameters on what's clinically meaningful, and I accept all of the caveats associated with that. It's certainly not perfect, but I think it does give us some indication of ways we can compare drugs without going through those tornado plots, which I don't necessarily think help us very much. So in conclusion, Belzutifan outperformed Everolimus from response and a PFS perspective. The toxicity profile was distinct, the quality of life was better, and so was the TWiST and the QTWiST analysis. I think this does help patients and it does help doctors make decisions. I quite like this type of exploratory analysis, and I'm happy to be involved in future projects with it. Many thanks for your attention.
Thank you, Tom. So now I'd like to invite Koral Shah.
Hi everyone, my name is Koral Shah. I'm a HEMONC fellow at City of Hope in Southern California. And today we are exploring health-related quality of life across renal cell carcinoma, a conceptual domain analysis. So existing health-related quality of life or patient-reported outcome tools may no longer fully reflect the experiences of patients with RCC given changing treatment landscapes. An evaluation of such tools has actually led to a new and tailored health-related quality of life measure, which was recently presented at ASCO 2025 by Cris Bergerot. She's a psychologist in Brazil and has been spearheading this work since 2022, along with many in the audience here today. And so, how did the FKSI-23 come to be? Patients across the US, Brazil, and Europe rated the relevance of each item contained in existing quality of life tools as listed above through a 54-item survey. Then experts and patient advocates helped, and the new and improved FKSI-23 was born. The FKSI-23 has 23 items, 10 of which are relevant to patients with localized cancer, and 13 items are relevant to patients with metastatic cancer. So while the FKSI-23 is being validated in 2 trials, we went back and explored the differences in the perceived relevance of quality of life domains between patients with metastatic and localized renal cell carcinoma. So how did we do this? Of that initial survey, those 54 items were grouped into these 4 categories based on thematic alignment. So you have items that were related to disease-related physical symptoms, disease-related emotional symptoms, treatment side effects, and function and well-being. And of the 200 patients that filled out the survey, here were the breakdown. About 59% of patients had metastatic RCC, and 41 patients had localized RCC. And of course, you can see that in the metastatic cohort, these are the patients that get targeted therapies and combination therapies. So here is a snapshot of patients, of the percentage of patients who found items relevant on this large 54-item survey. You can see that in the metastatic cohort, patients found about 15 items relevant, whereas in the localized cohort, patients really found about 6 items relevant. So what were these patients really interested in? Here is a breakdown of the quality of life priorities of each subgroup. So you can see that patients with metastatic disease found physical symptoms and treatment side effects to be very relevant to their care, whereas patients with localized disease really focused on function and well-being. And there was no significant difference between each group for emotional disease-related symptoms. Main takeaways are that patients with metastatic disease prioritize their physical symptoms and treatment side effects, which really emphasizes the burden they face with systemic therapies and having advanced cancers. Whereas patients with localized disease prioritize function and well-being, and this is potentially linked to surveillance-related anxiety that they go through. In conclusion, we need stage-specific patient-reported outcome measures that combine both emotional and physical dimensions of care in RCC, and the FKSI-23 is the tool to do this, and it is currently being validated right now. So thank you so much to Chris Bergeron and my mentor, Monty Paul, along with many in the audience today who have contributed to this.
Thank you, Koral. And so now we have Chad Tang.
Oh, you got my microphone too. Hello? Okay. All right. Thank you, everybody. Thanks for the opportunity to present today. I'm here to talk about radiation therapy instead of systemic therapy for a group of patients with oligometastatic disease. So, as we know, systemic therapy is very effective for this cancer. I know my audience here. And over time, this has even become more effective. But the doublet of systemic therapy, they do have costs associated with them and side effects, as listed here. And in patients with more limited disease, maybe there's an opportunity to do radiation therapy serially instead of systemic therapy and kind of hold that systemic therapy back. So we decided to kind of investigate that in this trial. In addition, we recognize one of the most important things about utilizing this strategy is a biomarker to assess who can be put into that strategy. So one of the things we employed is looking at ctDNA. However, there are certain caveats with using ctDNA in renal cell carcinoma. Number one, it's a low-shedding tumor. We know that through multiple studies. Number two, it's very heterogeneous. So if you sequence one area, you find a lot of private mutations that are not going to translate to other areas. And also, it has low mutation burden relative to other tumors. If you compound that with the fact that these patients on our study are low-volume oligometastatic, it adds even more complexity because they're going to be even lower shedding than your run-of-the-mill metastatic patients. So this was our trial. We took patients with oligometastatic clear cell renal cell carcinoma up to 5 Mets, and we radiated all sites of the disease and then followed them afterwards. At a time of progression, if they had up to 3 Mets progressing, then they could go back around the loop and have more radiation therapy and not start systemic therapy. However, at the polymetastatic progression, more than 3 Mets, or a site that we could not treat, then they went on and started frontline systemic therapy. Now, an important point here is the primary endpoint of systemic therapy-free survival. We saw from Brian Reeney's study that time to initiation of systemic therapy was 14.9 months with an upper limit of 25 months in the confidence interval. So we pre-specified that we're only interested that this is positive if the systemic therapy-free survival beats 24 months, because this is a round number. So that was our pre-specified, is this a successful trial or not, based on what Brian saw in his surveillance trial. So these are the primary outcomes for the patients. So the progression-free survival they're mixed actually. Systemic therapy-free survival was 34 months, and the progression-free survival was 17.7 months. So the systemic therapy survival of 34 months beat our pre-specified threshold for success of 24 months that we wrote into the protocol. And systemic therapy survival of 17 was also very, very promising as well. Overall survival, which did not reach the median overall survival, was 3 years, 86.5%, also very positive. Now, in terms of adverse events, they were pretty modest. We saw a 20% rate of grade 2 and higher toxicities. Grade 3 and higher was 6.7%, 1 grade 4 toxicity, which was hyperglycemia, and then no grade 5 toxicities. Now, moving on to circulating tumor DNA. So in these low volume patients, about 60% of them were ctDNA positive at baseline, and these were very low amounts of ctDNA, so 22.5%. And at 3 months, about a quarter of the patients who were ctDNA positive dropped to ctDNA negative. Now, as you can see from the Sankey plot, a lot of the patients who were ctDNA negative did well. They had more than 2 years systemic therapy-free survival, while those who were positive at 3 months, they did poorly. And that can be illustrated more thoroughly here in these Kaplan-Meier curves. So at baseline, circulating tumor DNA that was positive was a predictive WAD outcome, and this was even more so at 3 months follow-up. Oops. So in conclusion, metastasis-directed therapy without systemic therapy exhibited a promising efficacy with a median systemic therapy survival of 34 months, so almost 3 years, which met the pre-specified goal of greater than 24 months. They also had favorable overall survival with 3-year overall survival of 87% and toxicity profile, which was very manageable, of 6.7% in all patients. We recognize biomarkers are needed at baseline select patients, and we believe that ctDNA could play a role in that. So thank you.
Thank you, Chad.
Hello, good afternoon. So first of all, I would like to thank KidneyCAN for the opportunity to present my favorite topic, is the gut immune checkpoint MADCAM1 in patients with renal cell carcinoma. So the gut microbiota is a key player in cancer immunity. Understand how it modulates the immune response and the treatment efficacy help us to develop targeted therapies and also biomarkers to select patients for microbiota-centered interventions. The MADCAM1, when binded to the integrin alpha-4 beta-7, regulate the trafficking of immune cells from the gut to the systemic immunity. We demonstrated that in the context of the gut dysbiosis, there is a disrupt in this axis. MADCAM1 is downregulated, releasing immunosuppressive cells from the gut to the tumor, leading to tumor progression. We evaluated circulating MADCAM1 that correlate with the gut transcriptome in 3 independent clinical trials of individuals living with metastatic kidney cancer treated with standard therapies. First, we demonstrate that high MADCAM1 levels are associated with improved survival in this independent of the treatment arm in the Javelin Renal 101 trial. Moreover, MADCAM1 may have an added prognostic value to IMDC. More than the baseline levels, individuals that have persistent low levels after 3 months of the therapy have a poorer survival. And interestingly, low MADCAM levels are associated with pro-inflammatory microbes such as P. mammardii and also prototypical enterocluster that is associated with antibiotic-related gut dysbiosis. And soluble MADCAM levels anti-correlate with the number of SIG1 that is our fecal signature of gut dysbiosis. Using a cytokine multiplex panel in the Javelin Renal 101, we show that low MADCAM1 levels are associated with an angiogenic immune phenotype, and these data were validated also in the Nivohen clinical trial. For key messages, we show that soluble MADCAM1 is prognostic biomarker for RCC. Low MADCAM1 levels are associated with poor outcomes, but also distinctive pro-inflammatory microbial immune phenotype. We propose soluble MADCAM1 as a dynamic biomarker for tracking dysbiosis-driven immune response in patients with renal cell carcinoma, and also as a potential therapeutic target for microbiota-centered interventions in treatment-resistant RCC. I would like to thank all the study participants and caregivers, and also my rich scientific commensalism. There are some collaborative projects that can make us resistant to collaboration projects. This one was not the case. So first, I would like to thank my mentors, doublet of Laurence. I have Laurence Dittivogel, Laurence Albiges, Tony Shoiri, but especially for the friends that I acquired during this project, René and Mark. You are amazing. Thank you.
Thank you, Carolina. And Yu-Wei Chen.
Good afternoon. I'm honored to be here on behalf of my co-authors, and I would like to thank the scientific committee for choosing this abstract for presentation. Oh, sorry. Which one? This one? Oh, sorry.
This one, I think.
Oh, this one. Okay. Yeah, so here is highlights the background of the BHL-HIF2 alpha and CNI axis, and it is well known to our audience of the background science of the clear cell RCC, and CNI has been used as a diagnostic IHC marker, as well as now an imaging and therapeutic targets. So this is a collaboration with the KCRS team, and we utilize their CoData database, which collects the DNA and RNA sequencing on clear cell RCC specimens. CNI and HIF2 alpha expression was measured as transcripts per millions and dichotomized as high versus low based on quartiles. And the endpoints of interest were overall survival, as well as the Belzutifan time on treatment. Kaplan-Meier analysis was used to present the survival curves, and the p-values were determined by the log-rank test. So we have 764 clear cell RCC tumors, including our analysis. 57% of them were from the primary kidney tumors, and the rest were from metastatic tumors. 73% of tumors were male, 65% were white patients, 4.3% were African Americans, and 2% were Asian or Pacific Islanders. We have 71% of non-Hispanic patients, and the median age in our cohort was 63, ranged from 28 to 88. Here we found that 82% of our clear cell RCC tumors had VHL DNA mutations. The red boxes here highlights the CA9 RNA expression as well as the HIF2-alpha RNA expressions in the primary kidney tumors compared to the metastatic size. As we can see here is that the CA9 and as well as the HIF2-alpha expression are relatively higher among the primary kidney tumors compared to metastatic sites. Here showing you the CA9 HIF2-alpha expression by race and ethnicity subgroups. As we can see here, the CA9 HIF2-alpha expression were quite similar among the race subgroups across white patients, African Americans, as well as the Asian or Pacific Islanders. Similarly, we found that those two RNA expressions were similar comparing Hispanic versus non-Hispanic patients. Here showing you the overall survival by CA9 and HIF2-alpha expression comparing the fourth quartile versus the first quartile. As we can see here, higher CA9 RNA expression was associated with longer median overall survival with a hazard ratio of 0.55 with a p-value of 0.005. Similarly, higher HIF2-alpha expression is associated with improved overall survival with a hazard ratio of 0.56 and a p-value of less than 0.001. This is a subgroup analysis among Belzutifan treated patients, and we had 80 Belzutifan treated patients included in this subgroup analysis. And because there was only one Belzutifan treated patient that falls into the first quartile category, so therefore we dichotomized the CA9 expression at a median. As we can see here, CA9 expression was not associated with median overall survival among Belzutifan treated patients, and also CA9 expression did not predict Belzutifan time on treatment in this subgroup analysis. Here showing you is the subgroup analysis among Belzutifan treated patients by the baseline HIF2-alpha expressions in VHL mutant patients. Again, we didn't see any association of the HIF2 expression associated with Belzutifan treated patients, or the HIF2 expression was not associated with Belzutifan time on treatment. So in conclusion, CA9 HIF2-alpha expressions were relatively higher in primary kidney tumors versus metastatic tumors, and their expressions were quite similar across racial or ethnic subgroups. And CA9 HIF2-alpha expressions was associated with improved overall survival. However, we didn't see CA9 or HIF2 expression predict treatment response to Belzutifan, although the results might be limited by small patient numbers. Our findings provide important context for the potential clinical implication of the CA9 PET imaging, CA9 therapeutics, as well as the HIF2-alpha inhibitor in clear cell RCC. In the end, I would like to thank all the collaborators again. I would also like to thank Dr. Rena McKay, who mentored in this project. Thank you very much.
Thank you, Yu-Wei. Thanks so much to all the speakers. That was wonderful. So we're going to take a few minutes for questions. While we're getting the mics out, maybe I'll start with a question for Tom. Tom, so the QTWiST platform looks like it relies pretty heavily on a dichotomous variable of whether or not there was a grade 3 or 4 AE. And I would argue that not all grade 3 AEs are created equal, and maybe a grade 3 anemia is less impactful on a patient's well-being than a grade 3 stomatitis, for example. So do you think that actually Belzutifan was set up to underperform using this platform?
So I think it's, I think it swings and roundabouts for each of these toxicities, and it's a major problem with the entire field. 3 months of grade 1 diarrhea is a major problem, but that doesn't come up on your TWiST analysis. Whereas 1 day of grade 3 vomiting, that hits your grade 3. The beauty of TWiST is the 1 day of grade 3 comes up as 1 day rather than the whole longer period. So that kind of works from a duration perspective, but it doesn't work from a comparative quality perspective. And these criteria are set up for safety. They're set up for phase 1 trials, and they're set up for chemotherapy, whereas you're hitting really big parameters. When you hit those hematological toxicities, you get into grade 3 platelet drops very quickly, totally irrelevant. And if you had a month of grade 3 platelet drop, patients are fine. Mm-hmm. But so in the end, if you really want to have this conversation now, at this point in the life cycle of the development of technology, we probably should be switching to wearable devices, we probably should be switching to real-time patient assessment where they're scoring every day their quality of life, and then you could get real graphs. And it wouldn't be that hard to do. If you ask patients to say every day, just tick a box 1 to 10 on how they feel from a quality of life perspective, and then each patient will come up with their own beautiful graph. This is just a surrogate of that. But is it an accurate surrogate? I think when you look at all the other methods, it's probably better than all the other flawed systems we have, just about. Is it great? No. Can we do better? Absolutely. And the other bit is some of the other work going on, asking patients what they think is also important, because the patients are going to cross out grade 3 hematological toxicity, well, grade 3 platelets and other bits and pieces, and they're going to focus on those things like fatigue, nausea, the really important issues, peripheral neuropathy, these important issues. So it's a great question. In my opinion, we haven't done as well as perhaps we could in this area, and I think some of the other work going on around the world, and indeed work with wearable devices, have a huge role to play in the future.
Thank you. Yep, we got a question in the back.
So this is a question for Yu-Wei. So I don't know that we can extrapolate what HIF-2α protein levels are going to be from the RNA. And obviously the target of Belzutifan is the protein. But one thing that we could extrapolate from the RNA is that if there is no RNA, there is likely to be no protein. So maybe it'd be worthwhile if you feel that there are no pre-analytical confounders and that you have consistently good RNA quality across all of your samples, to look at those patients who have very low levels of HIF-2α mRNA, where you would expect that there would be little protein and no response.
Sorry, I missed your first part of the question. So can you speak louder? I'm a bit trouble here from hearing.
Yeah, I was saying that it's impossible to predict what HIF-2α protein is going to be based on the mRNA level. And of course, the drug target is not the RNA, it's the protein. So one thing that you could predict is that if there is no mRNA, there is going to be no protein, and if there is no protein, there should be no response because the drug is highly specific. So if you're sure that there are no pre-analytical confounders, because of course if all the RNA is degraded, HIF-2α RNA is also going to be degraded. So if you can exclude pre-analytical confounders, it may be interesting to look at those patients that have very low levels of HIF-2α RNA, where you would predict that there may be 0 responses as opposed to 23% response rate that we saw in the registration trial, assuming a similar patient population.
Yeah, that's all great comments. Yeah, I think our analysis was limited to what we have in a database, and since we have the overall survival and also only the time on treatment, obtained from the claims data. But I think your points are all well taken. It'll be interesting to be able to analyze further into those confounders and get more granular results for sure.
Other questions? Yeah.
This is for my friend Chad. Chad, congratulations for championing this trial 2018-0203 with delaying systemic therapy, treating oligometastasis with SBRT. Of course, I'm in your choir. We got the trial. We helped you enroll and get 121 patients in a few years. But for the rest of the people who are attending, and people, will be reading the last oncology paper and the people online, pitch why is this strategy a practice, potentially practice changing, that people who treat RCC, clear cell RCC, those patients that you define as having oligometastasis up to 5 lesions, why is this therapy should be pursued? Why should we delay systemic therapy and give SBRT? Because it's obviously, it's no-brainer. Somebody who is 80 years old, somebody who's younger but comorbid illnesses, or have this patient who has another competing threatening disease, like another malignancy that requires more aggressive therapy, obviously those patients should be either observed or treated with something non-systemic. But for the young patient who is healthy, where, we don't have those issues, with why is this strategy an important advance in the field?
Yeah. So that's a great question. I think there's no evidence to suggest that the local therapy, whether that be surgery or ablation or radiation, is going to make you resistant to the systemic therapy later on. So I always tell my patients, we're going to get you a good 3 years of high quality of life, low toxicity. Just come visit me once every 3 months and maybe get radiation. And we'll save the drug, put it in your back pocket for later. And the patients have loved that strategy. And we have some patients who have had 3 years, some longer, some shorter. So I think it really speaks to the patients when they can have a very prolonged period of time at the upfront, which is good quality of life, and then they'll know they'll have the drug still when they need it.
All right, we might have time for one more. Oh, right up front.
I just wanted to comment to Nazir's. We just closed the SOAR trial for poor accrual because we couldn't, randomize patients to sequential SBRT versus systemic therapy of their choice, but we couldn't get patients and providers to buy into the trial. It was very slow. So I think to answer, your question about why should we do this? I think Chad is answering what we can do right now, and without designing it in a different way, we can't answer that question.
So just to add to that, I think there is a piece around people in this room who are experts in this area and spend all day thinking about this and patients and early disease and stratification and working out those patients who don't need therapy. I pursue surveillance in a lot of my patients. When you look at a country like the UK, the proportion of patients who get first-line therapy is still much lower than we'd like it to be. And when we look at the choice of first-line therapy, VEGF-TKI is still commonly used. I think we need to be really careful about broadcasting at this point that actually you don't need systemic therapy and there are other approaches such as radiation therapy that are attractive alternatives without really robust data to support that. And so inevitably this discussion needs a balance between how do we maximize outcome on the one hand, have we yet got to that place correctly, number one, and the answer is no, we haven't, from the global community. And then in this room here, then we need to say, can we find a subgroup where we can broadcast to this bigger group of clinicians that there are alternative approaches that we are confident that it is at least as good, if not better. Because inevitably we all know that sitting on metastatic kidney cancer for some patients is not in their interest, and starting effective therapy early for some patients is really important. And early immune checkpoint inhibition, I think, saves lives. And that is the big finding that we've had. In the end, the 5-year survival associated with ipi-nivo, lempen, axi-pembro, and the transformative results from overall survival from 1 year to 5 years has been driven by systemic therapy, not by other approaches. And as we introduce those alternative approaches, we need to be careful that they're held to the same level of scrutiny as other approaches. Just because all of our hospital has radiotherapy machines doesn't necessarily mean we should all be using radiation therapy until we're confident we can select the patients correctly.
Yeah, so I agree with you, Tom. I think when possible, randomized evidence is best. But as Naomi pointed out, SOAR was closed early because they couldn't randomize patients to it. I always have a little analogy here, like how much data do we have for nephrectomy to a localized kidney cancer, randomized data? We don't have any randomized data for nephrectomy localized cancer. Doesn't mean it doesn't work, but we can't randomize them at this point. Now, I would love to do a randomized trial, and we are looking at biomarkers very, very hard, including ctDNA. We'll look at KIM1 with Vincent and Tony, and we're going to keep on digging into that to find out more biologically what the best subset is. But yeah, I know what else, but that's what I would add. Yeah.
And I think there is a getting to a place where you want to be, where you can generate that robust data without randomized. I'm not anti this. I'm really keen to say, I think countries like the UK, where we have a centralised healthcare system, there's no financial incentives of treatment A versus treatment B. We should be doing literally hundreds of patients in these trials looking at their long-term outcome. And I think that's really important for us. Unfortunately, we can't seem to be organised. It doesn't mean I don't like the approach. I would just like the data to be more robust at this point before we broadcast externally that this is safe and effective.
Fabulous conversation. Thank you, guys. So I'm going to invite up the next 4 speakers. Thank you. So we have Doris Singh, Ruchi Agarwal, James Jones, and Miguel Zugman. You'll be first. Yeah. Which is the green one?
This one?
Yep. So we have Doris Singh first.
Hi everyone, my name is Doris. I'm a senior research technician in the Ari Hakimi lab at MSK. And today I'll be talking to you about the influence of sex on immunosurveillance and metastatic tropism in novel mouse models of CCRCC. So, as we know, RCC is a very male-dominant cancer, with males experiencing twice the incidence rate and also more than twice the mortality rate of females. Now, many reasons for sex bias have been explored, not just in RCC, but across many different cancers. Males are often attributed to worse disease because of smoking, maybe the immunosuppressive effects of androgens, and specifically in CD8 T cell exhaustion. And then also the male loss of Y. Females, we get protection from exits genes and also from potentially the protective effects of estrogen enhancing our immunity prior to menopause. However, the role that the immune system plays in this gender disparity is still quite unclear, and so this became my focus. So the first thing that I did was look at existing CCRCC models, and so this data that I'm showing you was published in 2017 by the Ian Frew lab. They developed a VHL P53 and RB1 triple knockout CCRCC gem model, and they found that in females, the female mice displayed significantly lower tumor penetrance and lower tumor burden. We also saw this in our lab when we used the same mice. However, although this model is good, it still has several limitations, one of which being that these mice take like a long time to develop tumors, and so I needed a more rapid approach and one where I could study treatment response and metastases. So I'm very lucky in our lab. I have 2 incredible mentors, Lin and Hui, who developed 2 novel RCC models that recapitulate human disease. On the left is an ICB responsive model, HJRCC68N. This was developed using in vitro CRISPR techniques. It has VHL, BAP1, and CDKN2A and 2B mutations. This model responds well to immunotherapy. On the right side is an ICB resistant model, LVRCC67. This has the same genetic background as Ian Frew's KVPR gen model. This was developed using in vivo CRISPR techniques, and this model does not respond well to immunotherapy. We know that the tumor microenvironment is severely different between these 2 models, which could potentially explain why one responds to immune checkpoint therapy and the other does not. And so the first thing that I did was I implanted both of these models orthotopically, and 2 things were very apparent to me. The first one was that there was in fact sex bias in the growth of the orthotopic primary tumors, and 2, that this sex bias was in fact dependent on the immune system. So first, if we look at immune deficient mice, so these are NOD-SCID gamma mice, we see that actually females develop larger tumors. However, in the context of the immune system, when I looked at wild-type mice, you can actually see that the phenotype is completely switched. So now males are the ones that have larger tumors, which then represents what we see in the gem models and also in human disease. If we look at the metastatic setting, we see that, again, NSG mice are the ones that are developing lung and liver mets, but the wild-type mice, nothing. And so since in human RCC patients, they are usually dying from their metastatic disease, I was very keen on studying metastases in the role in an immune competent setting. And so I used metastatic derivatives of both of these lines to study this. So in both models, if you look at the liver, males have significantly more liver mets compared to their female counterparts. But in the lung, the metastatic seeding is actually completely model dependent. And that is one of the most striking things that we found in this metastatic model, where the metastatic tropism actually differs very differently between the two. So in the ICB responsive model, you can see that most of the mets are going to the lung. And in the ICB resistant model, most of it is going to the liver. If you look at the right-hand side, the LVRCC67 ICB resistant model, the female mice do not really develop liver or lung mets, and so this made immune profiling using flow cytometry very difficult. And so the next two slides where I'm showing you that flow data, it's going to be mostly for the left side, the ICB responsive model. So in the liver, we see that fewer liver mets for the females actually correlated with more ILCs in the liver mets. And in the lung, the immune landscape between the males and females are actually vastly different. So we see that males who have trending fewer lung mets, they actually have significantly more monocytes, DCs, and T cells, which then highlight antigen presentation and T cell activation. So in summary, we have two RCC models that recapitulate the sex-specific disparities observed in human RCC. The immune system plays a critical role in regulating primary tumor growth in females, and sex-dependent metastatic tropism is completely model-dependent. In the future, I will be looking to perform several targeted depletion studies where I will be able to assess the role of specific immune populations in sex-dependent metastatic tropism. And also with human data, I have the MSK impact cohort of more than 1,200 RCC patients where I can then interrogate the sex-derived metastatic patterns. So I just want to give a quick shout out to my mentors, Lynn and Hui, and of course my PI, Dr. Akimi. They've supported me all this time and put faith in me, and I really appreciate it. Couldn't have done it without you. And then I just want to thank our funding sources and as well as the organizers of KCRS. Thank you.
Thank you. We have Ruchi Agarwal. Yeah, you can use that one.
Good afternoon, everyone. My name is Ruchi Agarwal. I'm an undergrad at UPenn, and today I'll be talking about global disparities in clinical trial availability for renal cell carcinoma. As many of us know, clinical trials are key to advancing medical knowledge and improving patient care. In MRCC, clinical research over the past 2 decades has led to a 4-fold increase in median overall survival. However, most RCC trials continue to be conducted in primarily high-income countries. This raises concern about equity and generalizability, as many populations globally are being excluded from trial data. So the goal of this project was to analyze how RCC trials are distributed worldwide and to identify disparities in access based on country income level. So we started by consulting the National Clinical Trials Database for RCC trials conducted between 2019 and 2024. We excluded non-interventional, pediatric, and non-RCC trials. For each trial, we documented a few key features. This included sponsor, subtype, disease stage, phase, and whether or not the trial was multinational. Additionally, countries were split into their World Bank income level classification of high, upper middle, lower middle, or low income countries. Lastly, we used descriptive statistics to summarize the data, a Kruskal-Wallis test to assess differences in income level, and a Poisson regression to assess associations in income, GNI, RCC burden, and health expenditure. Now for our results. We documented a total of 357 trials. The vast majority, or 76%, were conducted in high-income countries. only 24%, or 84 trials overall, were conducted in upper middle, lower middle, and low income countries. Notably, we didn't see any significant difference in RCC subtype or disease stage across income groups. If you take a look at the figure, it shows the distribution of clinical trials by country. As you can see, the United States has the largest share of clinical trials by far, with 231. This next figure shows top countries by annual RCC mortality. Here, countries like India and China have a higher RCC burden, but comparatively fewer trials. This disparity underscores a misalignment between where clinical research is needed versus where it is being conducted. Next, we evaluated some other features. We found that pharma-sponsored trials were most common in non-HICs, while government and academic-sponsored trials were most common in HICs, both with significant differences. Late-phase and multinational trials were also more common in non-HICs. This suggests greater participation in collaborative or advanced stage research in countries that are not HICs. The pie chart and the table on the right corroborate this. Most trials occurred in HICs, and the odds of any country having a trial dropped steeply with lower income classification. Next, this slide shows some of our other statistical analyses that corroborated this evidence. Specifically, our Poisson regression showed that countries with higher health expenditure were more likely to host trials. This is visually reinforced with the scatter plot on the right, showing that the HICs are clustered in the top right. Overall, we concluded that RCC trials are disproportionately concentrated in high-income countries, with very limited inclusion of low-income countries. Non-HICs also rely heavily on pharma or multinational trials to even take part in this research. Thus, it's crucial that we expand RCC trials to these regions so that we can promote global equity in RCC care and improve the generalizability of trial findings. I'd like to thank my mentors, Dr. Paul and Dr. Rahina Barragan-Creo, for this help on the work, and everyone else who contributed to it. Thank you.
Thank you. We have James Jones next.
Hi there, so I'm Dr. James Jones. I'm a consultant oncologist based at Cambridge in the UK. Thanks for the opportunity to present today. It's been a really fantastic day of talks. I'm going to be talking about the WIRE clinical trial. So WIRE is a multi-centre platform study based in the UK. It's a window study, so we approach patients who have operable clear cell kidney cancer. It's got 5 investigational arms. The first 3 focus on cediranib and olaparib in combination, and arms 4 and 5 are looking at novel bispecific immunotherapies. So, as I mentioned, it's for operable clear cell kidney cancer, so we approach patients, and then between the window of diagnosis and surgery, they receive 1 cycle of drug. And for arms 1 to 3, the primary endpoint was a reduction in vascular permeability as assessed by contrast MRI, so a metric called K-trans. But in addition to that, we have a detailed program of translational science to try and understand the mechanisms to what's going on with these patients that comprises tissue, imaging, and blood biomarkers. So this summarises the recruitment for arms 1 to 3. So the trial uses a Bayesian adaptive design, so we can alter the number of patients recruited to each arm based on interim analysis. This allows us to really efficiently allocate patients within the trial, and the numbers of evaluable patients are summarised there in brackets. So going on to the primary outcome data then, so as I mentioned, the primary outcome for arms 1 to 3 was a reduction in K-trans with some representative images shown there, so what it looks like on the MRI scan. So what we saw in arm 1, so cediranib, we saw 4 patients had a 30% reduction, and then in arm 2, which was the combination arm, we saw another 4 patients, but no responses in the olaparib containing arm. Then thinking about the secondary outcomes, so critically, all the patients in the study had surgery within the planned window. So that's really important for us. So in the neoadjuvant setting, no patient missed their operation because they took part in the trial. There were a small number of grade 3 adverse events which were consistent with the known mechanisms of the drug. And then more recently, we've got the extended secondary outcome data. This is very recent data first presented here. So looking at tumour volume, we again see consistent reductions in the cediranib containing arms, but fewer responses in the olaparib-containing arm, in fact just one. And then we also look at CD8 T cells pre and post treatment, and again we've seen some increases in the, particularly in the combination arm. We're now going to go on to the exploratory analysis, so we're really keen to understand in detail what happens in each patient. So some of the first data we've got back is plasma antigenic cytokines, and so we see in arm 2 in particular that we get induction of two factors, so placental growth factor and VEGF-A before surgery. And this relates to a finding that we saw in our previous study, which was NAC-SIVA. So NAC-SIVA was a neoadjuvant study of axitinib for kidney cancer with tumour thrombus. And in that study, we saw that patients who had a good response had a stronger induction of placental growth factor. So again, we wonder if and why this is an early indication that there might be some interaction or synergy between olaparib and ctDNA. Other things we're interested in include defining different tumour environments, looking at extended MRI metrics. So in addition to the K-trans, we also get other metrics, and we're trying to use that to define different areas of the tumour that might be associated with response. And then looking sort of beyond that, we're interested in integrating different metrics together using machine learning approaches as we did in our previous study, and that's something that Rebecca, our PhD student, is working on at the moment. So just to summarise then, we saw some responses in K-trans, vascular permeability in ctDNA-containing arms, although not in the olaparib arm on its own. We've also seen tumour reductions and some induction of antigenic cytokines that we're looking into further. So wire continues in arm 4, so we're actively recruiting now to volrustomig, which is a novel bispecific immunotherapy from AstraZeneca. We're just up to 10 patients there, and we're really excited to see the outcomes from that arm because it's a new immunotherapy drug. And of course, wire then, now it's established, gives us this platform where we can go and look at mechanism in the neoadjuvant space for kidney cancer. So thanks again for listening. Again, this acknowledges lots of people who are involved in making wire a success, and of course the patients and their families who took part. Thanks very much.
Thank you. And Miguel Zugman. This one.
Good afternoon. I'm a clinical oncologist from Brazil, currently a research fellow at City of Hope. I'd like to thank you for the opportunity to present this real-world analysis of first-line systemic therapies for metastatic papillary renal cell carcinoma. Despite growing use of IO-based regimens and MET inhibitors in recent years, our findings showed no clear survival benefit across treatment classes, highlighting the ongoing uncertainty in managing this disease and the need for randomized trials. Our goal was to evaluate the comparative effectiveness of first-line systemic therapies in metastatic papillary RCC using real-world data drawn from a large, nationally representative oncology cohort that includes both community and academic sites. This study used ConcertAI's patient 360 dataset, which includes de-identified, human-created data. It integrates multiple electronic medical record systems with pharmacy and medical claims, as well as third-party mortality data. We identified 216 patients with metastatic papillary RCC who received first-line systemic therapy between 2016 and 2024. Patients were grouped into 5 treatment categories: VEGFR TKIs, MET inhibitors, IO, either monotherapy or IO-IO combinations, IO-based combinations with VEGFR TKIs or MET inhibitors, and a smaller group receiving mTOR inhibitors. Our primary outcomes were real-world progression-free survival and overall survival, assessed using Kaplan-Meier curves and multivariable Cox regression. Here's a summary of baseline characteristics across treatment groups. The largest group received VEGFR TKIs, followed by IO, MET inhibitors, IO plus MET, IO plus TKI, and mTOR inhibitors. Patients had a median age of 66, and approximately 3/4 were male. Nearly 90% were treated in community oncology practices, and few patients identified as Hispanic or Latino. This slide shows the shift in first-line treatment patterns for metastatic papillary RCC between 2016 and 2024. There was a sharp decline in the use of TKI monotherapy over this period. We observed a steady rise in both IO and IO combined with either TKI or MET inhibitors, which together became the predominant approach in more recent years. Use of MET inhibitors peaked in 2022, though remained modest in absolute numbers. This figure shows real-world progression-free survival by treatment class. Median real-world PFS ranged from 2.3 months in the IO plus TKI or MET inhibitor group to 5.4 months in the TKI monotherapy group. IO and MET inhibitor groups showed intermediate values at 4 and 3.6 months, respectively. The mTOR inhibitor group had the shortest PFS at 2 months with a visibly separated curve, though the subgroup was small. No statistically significant differences were observed across the main treatment categories in multivariable analysis, apart from the mTOR group. Overall survival showed a similar pattern. Median OS ranged from 9.3 months in the IO plus TKI MET inhibitor group to 18.6 months in the IO group. MET inhibitors and TKIs had comparable OS estimates, 14.7 and 14.6 months, respectively. Except for the mTOR subgroup, no statistically significant survival differences were detected. In conclusion, this real-world analysis of first-line treatments for metastatic papillary RCC did not show clear survival advantages across treatment classes. Despite the increasing uptake of IO and IO-based combinations, their real-world effectiveness appeared comparable to standalone VEGFR TKIs and MET inhibitors. These findings highlight the persistent uncertainty in optimal first-line management for papillary RCC. Prospective randomized trials such as PAMET2, SAMITA, and Stellar 304 are critical to addressing this gap and guiding evidence-based treatment strategies moving forward. Thank you to all collaborators and my mentor, Dr. Powles.
Thank you. All right, so we have about 5 minutes left for questions. And I saw this hand go up first. Sorry, Tom.
Question for Doris. The difference in the male versus female mice, we have seen the same thing actually in the experiments that we have done. In fact, you can exacerbate that difference just by using germ-free black 6 mice versus the one that have been conventionally housed. And we can discuss why that happens. The one concern with that experiment, though, is that male-specific antigens, because the original cell lines were made from male mice, could be triggering responses when engrafted into female mice. Thoughts about how you're trying to address this as a true dimorphism versus a rejection, immune rejection response?
Yeah, that's a wonderful question, and something that we've actually already thought about. I actually conducted a bone marrow transplant study where I did CD45.1 chimeras. So the whole goal of the study, so let me backtrack actually. So I put male and female bone marrow into male and female mice. So it's like male mice that got male marrow, male mice that got female marrow, and then same thing for the females. The whole point of this was to kind of tolerize. Let me backtrack again, sorry. So these cell lines were made in male mice, so we're saying, okay, if they're injected in female mice, is that rejection because there's actually a biological difference, or is it because they're just rejecting the Y on those male-derived cancer cell lines, right? So we basically tolerized the female system with the Y chromosome, so the female mice that got the male marrow, we saw the same thing. So I don't think it's that, if that answers your question. Yeah. I think this is a real biological difference.
So this question is also for Doris. So you show the HJRCC model where you inactivate VHL, BAP1, CDK2A and B. So you show some responsiveness toward immune therapy. I'm assuming those actually could show sort of heterogeneous response, probably potentially sarcomatoid features. So do you think that those immune responsiveness could correlate with some kind of sarcomatoid features when you look at individual tumors from those mice?
Potentially. My mentor created that line, so I would really suggest that you look for her poster during the poster session. I just used, I'm not sure I'll be able to really answer your question. I just used her line.
It is addressed to her.
Yeah, so I would seek that you find Hui in the posters in Prosecco. Sorry about that.
The LVRCC67 tumors in the subcutaneous model, they are very hard, probably due to the calcification. So in your orthotopic model, are they also very hard, the tumors?
It depends. So in the ICB resistant model, the LVRCC67 model, those tumors are really hard. And so the way that I was able to track the tumor growth, not only did I measure the tumor weight at the end of the study, but I also tracked them via ultrasound. So I actually have growth curves. But I found that the LVRCC67 line was very difficult to track using ultrasound because they were so hard, and we assumed that they were quite calcified. But the HJRCC68 tumors, those were quite soft. So those we were able to easily chop up and then process for flow.
Miguel, I liked your presentation. The real-world data, the foundations of real-world data is not strong and is open to huge bias. But what you showed was extremely provocative and potentially actually unhelpful. Let me keep going if I may. Sure. But the one caveat to that is if the randomized data we had available to us had clearly shown that VEGF-TKI therapy is much better than sunitinib, and it looks like by the graphs the clinical community in the US believes that the case, otherwise sunitinib wouldn't have gone to 0. If that were the case, and we had those randomized trials, then I'd say I actually think your presentation is unhelpful. But because the data we have today is based on single-arm trials, with all the caveats and biases associated with that, there is a possibility that what you've shown is true. Where do you internally sit with this issue? Do you think that your data is fundamentally flawed and incorrect? Or do you think the single-arm trials are flawed and actually the US has got this wrong and we need to wait for the randomized trials?
Thank you for your question. Definitely the data set might also suffer from selection bias, and we are definitely looking more into it, and especially to see if there's any increased prognostic risk factors in the population that received the more recent therapy, to see if that could be have biased the results. But definitely I agree with the morning sessions that we need the randomized trial to move forward and be sure that the field is moving to the right direction. So I do see it's vital and essential to have the prospective and randomized data to justify our practice.
Thank you so much, everyone. I think that brings us to the end of our session, but we have the posters next, so you can find out the speakers and ask more.